Hello, everyone, and welcome to the Dr. R Show. We'll be coming to your living rooms weekly to discuss various health topics with the help of medical experts in their respective fields. Meet my two very special assistants, Megan and Christina.
And I am so excited because today is leg day.
And then inhale as you lower back down.
They will be with me every week to give us tips on healthy eating and proper exercise.
Stretch and keep yourself hydrated.
So welcome to my show as we both learn together. Welcome to the Dr. R Show. I'm here with Dr. Kevin Connor. Dr. Connor was the former director of stroke at Texas Health Arlington. Thanks, Kevin, for being on the show.
Thanks, Jay.
We're here today to talk about stroke. You're a neurologist, so before we get on to stroke, what it is and all that, what does it take to become a neurologist? What's your education, training, and background?
So I did medical school like we all had to do, and then I did internship in general medicine, and then 3 years of neurology residency, and then spent another year doing some neurophysiology at UT Southwestern. And
stroke is something that a neurologist takes care of a fair amount.
Correct.
Yeah. So tell us about stroke. What is a stroke?
So stroke is a sudden neurological event. It's a event that just changes you as far as strength, as far as speech, as far as vision. But the key is stroke. It's like a stroke in time. It's just suddenly, all of a sudden you have something that's not working the way it was supposed to work before.
And how common is it?
It's actually pretty common. So we estimate that about almost 800,000 folks a year will have a stroke in the United States. So it's one of the more common entities that a neurologist will actually see.
And what causes a stroke?
Stroke is caused by several different things. The most common thing is basically a kind of plug in the pipe, if you will. And so there's a problem with blood flow to brain tissue. And once that blood flow stops, within about 4 minutes or so, brain tissue starts to die. And that's when you start having neurological symptoms.
So that's an ischemic stroke.
That's an ischemic
there
stroke.
Are other kind of strokes?
So there are other kind of strokes. So ischemic is 85% of what you do, and then there's what's called a hemorrhagic stroke. And a hemorrhagic stroke is where the blood vessel breaks, basically, and it bleeds into the brain tissue itself. So it can bleed from outside in, and sometimes it can bleed from directly into the tissue out.
So there's a condition known as TIA. Could you tell us what the difference between TIA and a stroke?
So TIA means transient, which means it's temporary, ischemia, which means a lack of blood flow, and an attack. And so that's what the stroke is, part of that. So TIAs, by definition, the neurological symptoms go away within 24 hours. What we're learning now, though, with some of the imaging techniques is, in fact, that's probably not a good definition anymore, because a lot of TIAs are probably little strokes that have clinically gotten better, but we still see some damage.
So what causes a blood vessel to clot off? What causes a thrombotic stroke?
So a thrombotic stroke can be related to plaque, so kind of cholesterol glue or goo that deposits within the wall of the blood vessel. It can fracture, and you can have these things called platelets that stick to the wall of the blood vessel, and it's basically calcium in the pipes. And so it just locks everything up, and anything beyond that's not getting the blood flow. It's not getting the water it needs anymore, and then it dies. It can also come from other places, so like from the heart. So if you have something called atrial fibrillation, it can break a piece of clot off, and that can travel downstream. If the piece is bigger than the hose, blocks it up, and lo and behold, you have a stroke.
And what are some of the signs and symptoms of a stroke?
So they vary. The signs and symptoms are depending upon which blood vessel actually gets closed. So it can be a little blood vessel that goes to the back of the eye, and all of a sudden it's like a little shade being pulled down. It's called amaurosis that develops. Or it can be to a speech center, where all of a sudden you start talking like in a foreign language, or you don't understand, you can't comprehend what's going on. Or you can suddenly have a facial droop, or an arm can go weak or heavy and become limp, or numb and tingle that's developed suddenly.
And is there a way to recognize a stroke early on?
So the American Heart Association has come out with a mnemonic that's really, really easy for most people to use, and it's called FAST. So F is for facial involvement, so it's the facial droop that some people will get with stroke. There's the arm weakness, that's the A part of that. There's the speech difficulties that you can get. And the most important thing is time, meaning for us, when did it happen? For the patient is get to the hospital, okay? time is brain, and that's a way to be able to preserve brain tissue.
And the way to shorten that time to treatment, the first part is, of course, recognition. You have to know, did a stroke happen?
Absolutely.
So educating the public is important because they may not recognize
that
what they're seeing as a stroke.
Correct.
Are there any efforts to do that?
There are efforts to do that, and so part of when we do stroke certification for specific hospitals, part of what we are required to do is to go out and actually do educational programs, so try to get that information out there. They had a thing at the ballpark, actually, that was part of stroke education as well, and so that's a good part of it. But also community service and the education ads that are out there also seem to help as well.
And so what can be done to shorten the time to treatment?
What we know is that if you call 911, you're more likely to be treated quicker than if you just kind of lazy-daisically kind of just drive yourself to the hospital. So that's one thing that can be done. Recognition is really important, so especially in men, because men tend to ignore symptoms a lot, and I've had patients that have just suddenly had their arm go weak and decided they're going to go to bed and see if it got better the next morning. So recognizing that, hey, this is not a normal thing, and hey, there is something we can do about it. Let's go to the hospital, let's get it checked out, because time is really, really critical for what we can intervene on.
Now, are seizures common with stroke? Is that one that presenting signs or symptoms?
It can be sometimes more with a hemorrhagic stroke, because blood is an irritant in the brain itself, and so you're more likely to see a seizure as a result of that. But typically, no, seizures are not a big initial presentation of a stroke.
Now, how common are seizures after stroke, once you've gotten over it?
They can. It depends upon where in the brain the stroke occurred, but they can occur about 10 to 15% of the time after strokes in particular areas of the brain. So sometimes we do have to put patients on medication to try to prevent seizures from developing.
We're going to take a quick commercial break, and we'll be right back.
All right, guys, it's great to see you back on Inside Fitness. I'm Megan, and this is Christina, and today we're going to be talking about working out the chest. Now, the chest muscles are the pectoral muscles, and they're really used in pushing type movements like the push-up, and we'll be demonstrating a few of those exercises today.
And ladies, lifting weights is for you too. So don't think that just because you're lifting weights that you're going to bulk up. This is really going to help you achieve that muscle tone that you've been looking for.
Now, the first exercise that we're going to demonstrate is the bench press. So, Christina, I want you to lie down with your eyes directly under the bar. And as you can see, she's going to grip the bar a little bit wider than shoulder width apart. And then now I want you to lift the bar off the rack and adjust it right above your chest. Now at this point, squeeze your shoulder blades together. This is really going to help isolate the chest muscles, but make sure that you're not arching your back and that your feet are flat on the floor. Now, Christina, inhale as you lower the bar right at the bottom of the sternum. Tap your chest very lightly, and exhale as you raise the bar back up above the chest. Now, while she's doing this, you'll notice at the lowering part, her elbows are at about a 45-degree angle to her torso. So just do a couple more. Inhale on the way down, exhale on the way up. And now we're doing this with the barbell, but you can also do this with dumbbells or with cables lying on a flat bench. Okay, so now let's re-rack the bar. Go ahead and sit up. Now this was the bench press, and now we're going to show you a single joint exercise, which is the dumbbell fly. So if you want to pull the bench out. Now she's going to start lying on her back again with the dumbbells. Now press the dumbbells up above your chest as if you're doing a chest press. Palms should be facing each other. And now you're going to inhale as you lower the weights out to your sides. There's going to be a slight bend in the elbows, just until you feel a slight stretch in your chest, and then exhale as you raise the weights back up above your chest. Now do a few more reps. And you'll notice that she's lowering it at her chest level and not at her shoulder level. If you do that, you're going to get a lot of extra strain in the shoulder, and we don't want to have any injuries. Just a few more reps. Okay, good. Now go ahead and sit up. And now, did you feel that a little bit more in your chest than you did?
Absolutely. The bench press is really kind of arms and chest, and I kind of like how that isolated it. All right, guys, so that's it for us today on Inside Fitness. We'll see you right back here, same time next week. Don't forget your cool down, always drink water, and never forget to stretch. Have a good week.
Hi, welcome Welcome back. I'm Christina and this is Megan. And today we are here to talk to you about my favorite part of the day, dessert time. Now I know it's not something that is typically essential in your diet, but to me it is all about the food for the soul. So I want you to be able to enjoy dessert, but be a little bit guilt-free. I love bananas, so we have two separate desserts that we're going to make today, the first being banana ice cream. So what we do is you want to go to the store and you get whatever type of bananas that you want. You could even do this with plantains if you're interested, but when you get them at home, you want to kind of leave them sitting out for a little bit so that they can ripen up. When their peel starts to get a little darker, that's when they're getting more ripe, which makes them sweeter and a little bit more pliable. So you want to pop them in the freezer, and then whenever they're frozen, we'll take them out and we're ready to go, which is where we are right now. So we have our frozen bananas. And then however you want to flavor them, you can do cocoa, you can do coconut, you can do mint, really whatever type of sort of natural seasoning you want to use is what you can use. I love chocolate, so we're using cocoa today. So we have our bananas and our cocoa, and that's it. We decided to use a food processor today because our bananas are still a little firm from the freezer, but if you leave them sitting out long enough, you can actually just squish them with a fork or with one of those tools that you use to make mashed potatoes at home. So here we go, we're gonna put these in the food processor. I went ahead and got 2 bananas just so I can make a little bit more. Okay, and we just wanna go ahead and put a little bit of the cocoa in. It's gonna be a little bit messy. All right. And then let's pop this baby on. Okay. Look at all that cocoa. So we're just gonna take it out, we're gonna spoon it in a bowl. And look at that, looks just like ice cream. It's a nice consistency of ice cream too, which to me is like the best part. I just really love that sort of creamy flavor. You wanna taste?
Of course I want to taste.
So good, right? I know, it's just like ice cream, but it's not, it's bananas,
That's
it's
delicious.
amazing. Okay, so then next we have what I like to call banana Oreos. You could also just think of it as like a banana ice cream sandwich. We're gonna utilize the freezer as well, but right now, as you can see, we have our bananas here. You know, they're a little bit ripe. You can see that they've gotten a little bit more ripe since we bought them at the store. We're just gonna go ahead and unpeel them. And what you're gonna do is you just wanna kind of cut them into little circles. So you wanna make sure that you slice them a little thin. We're gonna be making a little sandwich, so you have 2 on top of one another. So all you do is you take a nice little bit of peanut butter or almond butter, which is what we're using today, spread it, and then you pop the other one on top. Now, okay, obviously this is gonna be delicious, but it's a lot better when you put it in the freezer. So I'm just gonna kind of set it here. We've got wax paper over a cookie sheet, and the reason why we use wax paper is once they're frozen, we'll be able to pop them off a lot easier. So it's usually better to do wax paper rather than just sticking them right on the cookie sheet. So we just make a few more. I mean, typically, the amount that I use to fill up a cookie sheet is about 3 to 4 bananas once I kind of get them all cut. So like I said, it's nice and messy, but it's gonna be so worth it in the end.
Now, bananas contain 400 milligrams of potassium, which is important in nerve and muscle function. They're also nearly fat and cholesterol free. So you can actually use mashed bananas in replace of butter or oil in other recipes like cookies or any other sweet treat. So you really don't have to give up desserts completely.
So we hope you learned a lot today, and maybe this will give you another option when you're in the kitchen cooking and you're trying to make something fun and sweet.
We're back with Dr. Kevin Connor, neurologist. Dr. Connor, we left off talking about treatment of stroke. So if someone has a TIA and they ignore it, what's the chance that they're going to have a stroke?
So most people who have a TIA have a higher risk for developing stroke. And we know that within the first couple days, actually having had that TIA, that's a warning sign that a big stroke may actually happen. Generally within that first month is a real critical window, but that first 1 to 2 days is really the critical aspect of that. And at TIA, there are things we can do to help prevent stroke, and with that little bit of a warning, you got lucky. So now's the time to figure out why, and now's the time to intervene to make sure that we can prevent something permanent from developing.
Well, I'm a guy. I have a TIA. Being typical, I ignore it. What's the odds I'm going to have a stroke?
The odds that you're going to have a stroke after a TIA is about 5 to 7% in the next year or so. Okay, the majority of that odds is within the first 1 to 2 days, and it's actually fairly high at that point.
Getting back to treatment of strokes, we mentioned there's two types. There's thrombotic, where the blood vessel occludes, and there's the hemorrhagic, where there's bleeding in the brain. So when you show up in the emergency room and they diagnose you with a stroke, which of the patients can you give TPA, the agent that lyses or breaks up the clot, and which ones can't you?
And so that's the beauty of the CT scan, is it shows blood. So if you've got blood in the brain, you're not a candidate. You don't want to do a blood thinner if you've already got blood in the brain. If you're the ischemic stroke, the one that has the pipe basically plugged up, then that's the patient that can get the TPA.
And how quickly do you need to get the TPA on board?
We try to get TPA within 1 hour after confirming him with stroke and getting all the imaging stuff done, basically.
So is it an hour from the time you've had the stroke to the time you get the TPA, or is it from the time you hit the door?
It's from the certain criteria. There is now door to needle time is what we're looking at, and we're trying to shore that down. The bottom line is the fastest way we can do it is what we need to do, because the longer you wait, the more brain tissue you end up losing.
And is there a period of time after which it's too dangerous to use the TPA?
Yes, the TPA is a blood thinner, and so it can create a hemorrhagic stroke as a result of that. We know early on the risks are low. Once you get it past about 4.5 hours of doing TPA, the risk of hemorrhage goes up astronomically, and that increases the mortality rate associated with stroke once you bleed.
And how good is the treatment? How successful is TPA?
It's more successful than sitting there and doing nothing. And so it's not 100% by any stretch of the imagination. I can say that since I started practicing, we didn't have that initially, and now we have that initially, and we do see successes, and pretty dramatic successes, sometimes things that reverse to 100% on a pretty good regular basis.
And what's the risk of using TPA?
The risk of TPA, a blood thinner, and so the risk is that you create hemorrhage. So there are criteria that we use that exclude you from getting it. So if you had recent surgery, you don't want to give somebody a blood thinner if that was the case. If you had a recent brain hemorrhage, you don't want to give somebody TPA in that setting as well. So there is risk of bleeding, and it's about 7 to 10% in the best of circumstances, even after excluding some of those patients.
So then you convert a thrombotic stroke to a hemorrhagic stroke in that instance.
Yes.
And the treatment of hemorrhagic stroke, you got to call me.
You do. You got to call a neurosurgeon.
And I spent many years taking care of hemorrhagic strokes.
And crack a skull. Exactly
hemorrhagic
right.
stroke.
So.
Now, how often do you need to do surgery in a hemorrhagic stroke? Certainly not all patients require surgery.
They're not. And the age of the patient and the health of the patient really determines a lot now as to who you go in and do surgery on with a hemorrhagic stroke than it used to. We do know that the hemorrhagic strokes are far more fatal, and the outcome is far worse when you have a hemorrhagic stroke.
Now, what is the prognosis for a patient with stroke?
It's all over the map. So it really depends upon where the stroke was, and it depends upon how severe the stroke was. And so some patients 100% recovery, some patients get absolutely nothing back, and it could be anywhere in between.
And how often do you see 100% recovery? Is that common or is that rare?
It is fairly common. It is now. I mean, you do see it fairly commonly, and most importantly, we can prevent a second one from occurring. And so that's the good part about it as well.
Well, brings us to our next topic. How do you prevent a stroke?
So stroke prevention, when somebody comes in with a stroke, we look at several things. There are blood factors that can cause stroke, and so we address those blood factors. So things can make your blood clot when it's not supposed to. Biggest risk factors are cholesterol. So obviously getting that cholesterol down is really, really key. Blood pressure is another really huge key as far as prevention of stroke. Diabetes is something else that's out there. Tobacco, those are the really big risk factors that we see in regards to stroke prevention. And then there's medicines that we can use that try to prevent you from forming clots down the road. Or we can look at your carotids, and if your carotids are all clogged up, if they're 70% or greater, we know that if you go in and clean them out, you do better than if you just ignore them and leave them alone.
Now, at what point, speaking of carotid disease, at what point do your carotid arteries need to be cleaned out?
So the magic number, and that's been looked at in several different studies that have been out there, is 70%. So if they're 70% or greater, we do better, and we do 21% better than if we just try to manage it medically.
Well, say you find the patient never had a stroke. You do a carotid ultrasound. You find 7% constriction of the artery. Do you do surgery on that patient, or not?
Usually, no. And so an asymptomatic carotid stenosis, typically we will treat that medically, but a lot depends upon who you see. So if you see the vascular surgeon first, you're more likely to get your carotid done than if you see the neurologist or your internist first. But it's always worthwhile following that, making sure it's not progressing, but getting very, very aggressive with the risk factors.
Do you go on blood thinners in that instance?
I put patients on blood thinner in that instance. And cholesterol-lowering medicines stabilize plaque, and so it's another way to try to prevent strokes from developing. Really key, getting blood pressure controlled and addressing all those risk factors.
Now, of the blood thinners, which do you prefer?
That's a hard question. It seems like it would be really, really easy. We know that with atrial fibrillation, which is a funny heart rhythm that people will get where they actually throw clots off, blood thinners like Coumadin, blood thinners like you've seen the ads for Xarelto and Eliquis and all that, do better than what we call antiplatelet therapies. Aspirin, Plavix, and Agronox are the ones we use there. So in that circumstance, I think the information's out there very, very well. First stroke, first TIA type symptoms, generally an aspirin a day is effective for most patients.
Now, warfarin, how common is bleeding, unexpected bleeding, in areas that you don't want bleeding with some of these blood thinners, like warfarin or Plavix?
They can be fairly common. Plavix less so, warfarin without a doubt. It's a dangerous drug. You have to regulate it, you have to respect it, you have to know about drug interactions because a lot of things affect blood thinners.
Yeah, I remember a case that I took care of. It was a man that was on Plavix, warfarin, and aspirin, and he had a giant bleed in his spinal cord. So blood thinners can be dangerous.
They can be dangerous, so.
Dr. Yoder, thank you for joining us on the show. That's all the time we have. We have to wrap it up, and we'll see you all next week.